Hello, I'm Dr. Rhett Murray with the Spine and Neurosurgery Center. Today we're going to be earning CME credits discussing lumbar spinal stenosis, the ways to identify this condition through exam and radiographic assessment. We're also going to be discussing treatment options, including a new minimally invasive technique for decompressing the spine, as well as the X-stop, which is a spacer for the lumbar spine, which does no damage to the spine and opens up the spinal canal with minimal disruption of the soft tissues. First of all, we're going to be discussing diagnosis and radiographic review of lumbar spinal stenosis. Lumbar spinal stenosis is the narrowing of the spinal canal resulting in compression of neurological tissues. This is a degenerative condition that usually occurs in people over age 50. Some people are born with a congenital spinal stenosis, which also may make them more likely to develop spinal stenosis at a later age. This stenosis occurs from gradual wear and tear on the lumbar spine over years, causing enlargement of the facets and ligaments and compression of the neurological structures. This compression of the nerves may lead to pain, nerve damage, and dysfunction in the lower extremities. Lumbar spinal stenosis is the most common indication for spine surgery in the elderly. It occurs from 8 to 11% in our elderly population in the United States. There are more than 125,000 laminectomies performed in the year 2003 for this condition, and this financial impact and lost work hours equal billions of dollars in the United States. The natural history of lumbar stenosis is slow progression. This degenerative process occurs over years rather than months to days. Symptoms may remain unchanged for a long period of time and then rapidly worsen. Patients with severe symptoms may deteriorate and require surgical intervention. The symptoms of lumbar stenosis include low back pain and pain that radiates into the lower extremities, particularly pain that is a cramping pain in nature rather than a sharp electrical type pain. Also associated with lumbar stenosis are cramping of the lower extremities, problems with standing, walking, and self-supporting in the daily activities of life. These symptoms are often relieved by sitting and by bending the spine forward in what we call a kyphotic position. This slide shows the dynamics of lumbar spinal stenosis. The first lady is walking and standing erect. This causes her spinal canal to become compromised, producing pain, weakness, and cramping in the lower extremities. The lady in the middle is walking bent forward. This opens up the spinal canal, relieving her symptoms. You can see the third lady, who is sitting, is also slumped forward. This allows the spinal canal to open and decompresses her neurological elements. There is a cascade effect involved with lumbar spinal stenosis. As people become less active, they become more obese and their general physical condition deteriorates. This leads to depression and psychological problems and worsening of their comorbidities such as diabetes and heart disease. On the slide to the left, you can see a healthy lumbar spinal canal. There's adequate room through the foramina for the nerves to exit. The slide on the right shows that the facets and ligaments have hypertrophied over time and have now compromised the canal where the nerves exit the spine. The degenerative cascade in lumbar spinal stenosis involves both the facets and the lumbar discs, and this eventually leads to a very poor quality of life. The facet joints hypertrophy over time, again compromising the nerves as they exit the spine. The joints become lax and the bones begin to slip, resulting in subluxation, which exacerbates the compression of the nerves. The discs begin with small tears within them that eventually wear down, causing larger radial tears. The disc becomes disrupted internally and begins to resorb. As the disc resorbs, the bones rub, causing bird beaks, which we call osteophytes. Again, this compromises the canal even further. Here is an MRI slide showing the degenerative changes in lumbar spinal stenosis. On the right, you see a wide canal. The neuroforamina are not compromised, and you can see the white spinal fluid around the nerve roots. On the left, the facet joints have become enlarged and hypertrophied, particularly on the right side. You can also see that the ligamentum flavum has hypertrophied, compromising the canal in the center. The disc has also become degenerated and becomes more black in color. As the lumbar spine is extended or bent backwards, these hypertrophied facets and ligaments close down around the nerves, causing nerve compression. In flexion, the neuroforamina actually open, giving the nerve more room and less compression. Here's an MRI example of spondylolisthesis, which is the last stage of lumbar spinal stenosis. Between the fourth and fifth lumbar bone, the fourth bone has slipped forward and has caused worsening of the stenosis. There is also hypertrophy of the ligamentum flavum and facet hypertrophy, exacerbating the compression of the nerves at this level. The MRI image on the left is a slice out lateral showing the neuroforamens. The one with the arrow shows that the foramen is compromised. The nerve is at the superior aspect of the foramen and is being compressed from the front by bone and from the back by ligament. The MRI image on the right shows central canal stenosis. Again, the canal in the center is compromised by the ligaments and out laterally by the bony structures. Autopsy specimens confirm the MRI findings. To the left is a normal spine showing a widely patent lumbar canal. Below that shows a stenotic spine where the nerve roots are compressed both by bony and ligamentous components. This is also seen on the slide to the right. The spondylolisthesis that occurs with lumbar spinal stenosis usually only occurs to a level of grade 1, which is less than 25% slippage. This is 6 to 10 times more likely to occur at the L4 and L5 level than at any other level. We're now going to discuss treatment options for lumbar spinal stenosis. For mild to moderate symptoms of lumbar spinal stenosis, non-operative care is indicated. First of all, exercise and weight reduction reduces the symptoms by reducing the strain on the lumbar joints. Physical therapy strengthens the lumbar spine muscles, producing less wear and tear over time. Bracing reduces symptoms by putting the spine in a slight kyphosis, reducing the compression of the nerve roots, but should not be used long-term as it leads to weakening of the lumbar spinal muscles. Epidural steroid injections help relieve the inflammation of the nerve roots and have been shown to help the radicular-type symptoms. Pain can also be relieved by analgesic medications and opiate medications. Non-steroidal medications and muscle relaxers also help relieve the symptoms by relieving spasm and inflammation of the joints and nerves. Finally, modification of activities of daily living can help by reducing the number of times the spine is bent in extension and relieving the symptoms. When symptoms are severe or fail to improve with conservative treatments, decompressive surgery is needed. The classical decompressive surgery is called a lumbar laminectomy, where the entire lamina of the lumbar spine is removed in order to remove the compressive elements. There are newer, minimally invasive techniques that we're going to be discussing today. First of all, I'd like to go over some terms. The term foraminotomy means removing the opening of a foramen, which is where the nerve root exits the spine. A laminotomy is slightly larger than a foraminotomy and includes removing a portion, but not all, of the lamina, which is the roof of the spine near the foramen. A facetectomy is removing a lumbar spinal joint. This can be done on one side, but if done on both sides, would definitely lead to instability, requiring placement of hardware and a fusion. So again, on the left, non-operative care includes epidural steroid injections, physical therapy, drugs including non-steroidal medications and muscle relaxers, and lifestyle modification. On the right, surgical options include laminectomy, laminectomy with fusion when instability is present, laminotomy and facetectomy, and then minimally invasive techniques that we will be discussing, including the X-stop. The first technique I'd like to describe is microendoscopic decompression. Microendoscopic decompressive laminotomy is a new technique using minimally invasive techniques. Surgery is done through a small tube rather than a large incision, and it uses state-of-the-art endoscopic techniques to remove the compressive components of the lumbar spine. This technique requires a small 14mm incision off to the midline. It is localized using fluoroscopy. A small guide wire is passed through the muscle, and then the muscles are split rather than divided, which leads to less postoperative pain. A small tube is passed down to the surgical site, and then using a microscope and endoscopic techniques, a laminotomy is performed and the nerve roots are decompressed. This slide shows the fluoroscopic images to the left of the initial probe going down and then the tube being passed over the probe to allow access to the lumbar spine. The benefits to microendoscopic decompression are diminished tissue trauma, diminished muscle injury, an increase in the amount of decompression, and improvement in the visualization of the neurological elements. This technique decreases recovery time as compared to the classic lumbar laminectomy and decreases the time it takes to return to normal activities. A newer technique to treat lumbar spinal stenosis is the X-stop. This is an interspinous device which provides decompression of the lumbar spine. As we talked about earlier, symptoms of lumbar spinal stenosis are evoked by standing or extending the lumbar spine and are relieved by sitting or flexing the spine. The X-stop implant at the treated site limits extension and keeps the spine flexed, which decompresses the neurological elements. The X-stop device is a titanium metal implant. This allows MRI scans to be done at a later date. It's designed to fit between the spinous processes of the vertebral bodies in the lumbar spine. It's also designed to remain safely and permanently in place without attaching to any bone or any ligaments. The X-stop has a number of components. It is designed to limit extension at the treated site. The device is inserted laterally between the spinous processes. There's an oval spacer that keeps the spinous processes divided. The wings prevent any lateral or anterior migration of the device, and the tissue expander allows the device to be placed between the spinous processes. The beauty of this device is that the interspinous and supraspinous ligaments are maintained. This decreases the chance of any lumbar instability at that level. The device is not fixed to any bony structures, so will not produce wear and tear of them. It's also placed posterior to any neurological elements, limiting any risk of neurological injury from the procedure. Multiple biomechanical tests have been performed with the X-stop to ensure its safety. It comes in many sizes so that the proper size can be implanted in order to open up the spinal canal but not fracture the spinous processes. The pressure of the disc is not worsened by placing this device. The load on the facet joints is actually reduced, producing less wear and tear of the joint and less stenosis in the future. Multiple x-rays have been taken with patients bent forward and backwards to ensure that the kinematics of the device are safe for the lumbar spine. The X-stop has been shown to improve the size of both the central canal and the foramina. 84% of patients have had an increase in their foraminal area, and 74% of patients had an increase in their canal diameter. The X-stop is considered a minimally invasive procedure. It's done as an outpatient. Most patients go home the same day. Implantation of the procedure usually takes about 45 minutes, skin to skin. It can be done under local anesthesia, but also under general anesthesia. It requires little or no resection of bone and minimal dissection of soft tissues. The beauty of the X-stop is that it does not preclude any other treatment options, and if it fails to relieve the symptoms, more conventional surgery can be done at the same level at a later date. The X-stop has a low incidence of infection. It also has a low incidence of causing erosion of the bony structures where it's implanted. There's also a low incidence of migration of the device if it's implanted properly. There's almost no incidence of dural tear or other neurological deterioration. And there's also a very low incidence of creating instability or other changes to the mechanical properties of the spine. Like any device, however, problems can occur. Here's an X-ray of an X-stop which is migrated posteriorly after a fall. The good thing about the X-stop is, when it does fail, it moves backwards away from the neurological elements and does not lead to any paralysis. An IDE study comparing the X-stop to conventional laminectomy showed that the X-stop results were similar to the laminectomy group. The X-ray on the right shows the X-stop in its proper position. The X-stop procedure is approved for patients with both lateral and central stenosis and both bony and soft tissue stenosis. It can be placed in patients with up to grade 1 spondylolisthesis or 25 degrees of scoliosis. It's also approved for both single or double level disease. In patients with osteoporosis, it can be placed if their osteoporosis is mild and they have not suffered previous fractures of the lumbar spine. So let's review our treatment of lumbar spinal stenosis. Our options include conservative treatment, which we've discussed. This includes physical therapy, epidural injections, and lifestyle modifications. Secondly, we can perform a microendoscopic laminotomy, which is minimally invasive and usually allows a patient to leave home the same day. Finally, the X-stop is a new device which spreads the spinal canal, decompressing the spinal canal without removing any bony components. Thank you very much for your time. I hope this DVD has been informative and helpful in treating your patients with lumbar spinal stenosis. To receive your CME credits from Huntsville Hospital Corporate University, please complete the evaluation form and return it to Corporate University in care of Karen Christian. Thank you.